Hello, my name's Dr. Mark Levy. I'm a general practitioner in the UK with a special interest in asthma. And I work as a locum at the moment, but I was the clinical lead for the National Review of Asthma Deaths, which was published in the United Kingdom in 2014. And so my aim in this talk is really to share some ideas mainly to help general practitioners to improve asthma care with the aim of reducing, in fact, hopefully eradicating asthma attacks in their practice. So to start with, I'm going to talk about a young girl who died just before her 14th birthday because of an asthma attack. In fact, it was her 47th asthma attack in her last 4.5 years of life. Now, the girl was Tamara Mills, and I do have permission from Tamara's mother to talk about her case. She wants as many people to know what happened to Tamara to try and reduce the chances of something like this happening again. Now, I was the coroner's expert witness in her inquest, which was held in 2015. And the coroner concluded that Tamara's death was due to asthma and that this was probably preventable. In her final 4.5 years, Tamara had 47 asthma attacks, which included 24 attendances at the emergency department, 21 hospital admissions, 19 general practice attendances, and 20 reattendances in hospital shortly after treatment for her attacks. Now, one of the problems is that there was a marked failure to treat her asthma as a chronic disease. Tamara's asthma attacks were treated. In most cases, they were treated very well, and she was sent home without a referral to a specialist and without much modification of her treatment. And so she was sent home to continue doing what she had been doing before. There was poor communication between hospitals and GPs, and when she was discharged from hospital, she was usually discharged on a fixed dose of oral corticosteroids, usually for about 3 or 5 days, with no follow-up afterwards in most cases. Now, there was limited evidence of any follow-up, and there was a failure by healthcare professionals to recognize the severity of Tamara's asthma. And her asthma assessments were really based on her symptoms at the time that she was seen for follow-up in the outpatients department. Now, this slide shows you Tamara's last year of life. This was 2013. And you can see that she was treated for 9 asthma attacks during that year, which included 5 hospital admissions. And if you look at the data, you can see that she often had a reattendance shortly after being discharged from hospital. Each time she was prescribed a short course of oral corticosteroids, and as I said, these were usually for a fixed time period. And the sad thing was that Tamara had a life-threatening attack in November 2013, where she was admitted to hospital, and in the 36 hours that she was in hospital, her asthma deteriorated to the point where she had a life-threatening attack. And following that attack, she was followed up and seen by a very junior doctor in the hospital. This was 2 weeks after discharge. And she died 4 months later of an asthma attack. Okay, so why am I talking about this today? There was recently an inquest report on a child who died from asthma. This report was published in November 2023. And the findings by the coroner, and this was also published, it's online, I'll show you a link to it in a moment. The findings were very similar to many potentially preventable death lessons that we've learned over the last years. And this child had a life-threatening attack 7 months before he died, and then subsequently was treated for 4 asthma attacks in his general practice. He was given 4 courses of oral corticosteroid tablets for acute asthma. before he died 7 months later. He was not referred to a specialist, and there were a number of other known modifiable risk factors for asthma death in this boy's story. And these included excess short-acting beta-agonist bronchodilator prescriptions and insufficient preventer prescriptions. And so this is the coroner's report, which is available online, so I'm not breaching any confidentiality. This is known and has been in the press. And she described the consequences of failures by healthcare professionals to recognize the severity and frequency of his asthma symptomatology, and also that his risk to his life was obvious. She said further that William's death was contributed to by neglect and that it was avoidable. She also said there were multiple failures to escalate and treat William's very poorly controlled asthma by healthcare professionals that would and should have saved William's life. She described the courses of oral corticosteroids that I mentioned earlier, and these were prescribed for attacks of his asthma in December 2020 and then February, April and May 21. And this was after his life-threatening attack in November 2020. And she said that these courses of oral corticosteroids were insufficient to effectively manage his obviously poorly controlled asthma. And she also mentioned that he was prescribed excessive reliever inhaler prescriptions and insufficient ongoing preventer medication. And so I'm using this case as an example in this talk, and also I'm going to provide some suggestions for general practitioners, particularly in the United Kingdom, to take action. Now, as I said, I'd really like you to put yourself in a position where you can imagine that there are no asthma attacks in your practice by 2025, or at least that there are no repeat asthma attacks in patients who have been seen in your practice or in hospital by 2025. Now, we've known that there are risk factors for over 60 years. The first reports in the UK on preventable asthma deaths were in 1967. Now, the British Thoracic Society published a report on preventable asthma deaths in 1983. The National Review of Asthma Deaths, which I led, published its findings in 2014. There was a Nuffield report on childhood asthma deaths in 2019. And there have been a number of coroners' Regulation 28 statements. And these Regulation 28 statements are issued by coroners when they think that there are lessons to be learned from deaths which the coroners believe were preventable. And for my colleagues who are really tired of me banging on about this for many, many years, the question you can ask is, how can I shut Mark Levy up? Or can I do something in my practice to change the way that asthma is cared for? So what I'm presenting here is a 7-step plan, and I'll go through these in detail. So the steps are, firstly, agree to tackle asthma in your practice and to track progress of your management. Agree a regular time slot. Now this might be once every week, it might be once every 2 weeks or once every month, depending on how many patients are having attacks in your practice. Establish a system to identify patients who you're going to review in these meetings, and agree standards of care. So what do you expect in your practice when asthma is being managed? And I'd suggest you use or adapt a structured template for reviewing these cases, and I'll provide one on my website. Identify any modifiable risk factors in the time leading up to the meeting that you're going to hold, and then at the meeting, agree a process to address those problems that can be dealt with and delegate tasks to individuals in the practice to implement. So, where do we start? Let's accept that an asthma attack is a signal that something serious has gone wrong and we need to do something. Accept that asthma is a chronic disease and agree to aim to reduce asthma attacks in patients in the practice by 2025. Also, agree to ensure accurate coding of asthma attacks. I don't know if you noticed in Tamara's record, very few, and the records were what I produced for you on the slide, very few of those attacks were actually coded as asthma attacks. If you code it as an asthma attack, then a doctor or a nurse consulting a patient will get a clear clue that this person is having multiple attacks. And then agree to meet for about an hour every 2 or 3 weeks, depending on how many asthma attacks you are experiencing in your practice. So, you'll need to collect some statistics in order to monitor your progress and see how you're doing. And I'd suggest these factors: the number of people in your practice diagnosed with asthma, the number treated with short course of oral corticosteroids, the numbers treated in accident emergency or the emergency department for asthma or wheeze, the number admitted to hospital for asthma attacks, the number prescribed 3 or more salbutamol inhalers. Now that's salbutamol or terbutaline. These are the short-acting beta-agonist bronchodilators that we prescribe for relief of asthma. The number prescribed for inhaled corticosteroid inhalers. Now ideally, there should be, your patients should be collecting more than 75% of the inhaled corticosteroid inhalers that you've prescribed. So if you've prescribed an inhaler which requires 1 a month, you'd expect your patient to collect at least 8 of those in a year. Or if you want a shortcut, count the number of those patients who've had less than 4 inhaled corticosteroid inhalers in the last 12 months. So these are all signals that asthma care is below standard. Establish a system to identify those patients who you're going to review in your practice meetings. And what I'd suggest is you set up a regular search of the practice computer. If you're having your meetings every 2 weeks, then set up your search 2 weeks ahead of the meeting. Identify those patients who are coded with asthma attack or acute asthma attack or oral corticosteroid prescriptions. That's prednisolone usually. It might be dexamethasone, but we usually prescribe prednisolone for these attacks. Identify those patients who've had hospital admissions for asthma, those who've been seen in casualty, and those who've seen the out-of-hours emergency attendance service for asthma. Okay, so we come to step 4 of the 7-step plan, and this is to agree standards of care. So these are standards that you're going to measure yourselves against in the meetings that you hold to discuss these patients. So firstly, anyone who has asthma or who has been treated with an inhaler should either have a diagnosis of asthma on the computer system or a code which says something like suspected asthma or possible asthma. And these attacks should be coded for anyone who's had an oral corticosteroid prescription, anyone who's been treated with high-dose short-acting beta agonists, so that's been nebulized with salbutamol or given 6 or more puffs of a short-acting beta agonist through a spacer, anybody who's been admitted to hospital for asthma or been seen in the emergency department for asthma or been seen out of hours by the out-of-hours service. Anybody who has been treated for an acute asthma attack should have a post-attack review, at least within a week of the attack, but ideally before the oral corticosteroids run out. And all attacks should be reviewed in this practice meeting that you're setting up. And in that way, you'll be able to identify the reasons, the potentially preventable reasons why people have attacks in order to modify treatment for those patients, but also to change practice so that other people with asthma are treated and that risk is identified in time before attacks occur. Okay, So step 5 is really to help you think of a process for structuring your reviews of these patients before your meeting. So what I'd suggest is that you summarize information on each patient who's been identified in that 2-weekly search. And if you have got high numbers of patients having attacks, my first question is why? Why are you having many patients having attacks? But if you are strapped for time, to start with, you could stratify those patients. Perhaps start with those who've been seen in emergency department or in hospital who've been admitted. But ideally, you should look at every single patient who's had an attack in your practice. And why? Because the next attack might be a fatal one. And we know from lots of research that asthma deaths occur even in patients with so-called mild asthma. Those are people who have infrequent or very few asthma attacks in their lives before they die from their asthma. We know, in fact, that about 30% of people reported in asthma death studies are thought to have had mild asthma by their healthcare professionals. So allocate these patients to clinicians in the practice. Now, I would suggest clinicians, if you're allocating this to a nurse or a pharmacist, make sure that they are well trained in asthma care and able to spot risk factors within the records that they're evaluating. I'd suggest use a template to identify the risk factors, and I have provided a sample attack evaluation form on my website at bigcatdoc.com. Step 6, you identify modifiable risk factors and then discuss these at the practice meeting. Now, obviously, once you've identified risk factors, like, for example, excess prescriptions of short-acting beta agonists, by which I mean 2 or more in a year, insufficient inhaled corticosteroid inhaler prescriptions. Now, these might be prescriptions issued or prescriptions collected. So you need to check the computer system and see whether, first of all, whether inhaled corticosteroids have been prescribed, and if not, why not? And then count the numbers that have been issued in the last 12 months. If you've been prescribing an inhaler which requires 1 a month, then you'd expect 12 to be picked up in the last 12 months. At least 8 should be picked up. And then provide an update or a new plan for the patient. This is a self-management plan to help a patient recognize danger signs and to know what to do if this happens again. Has the inhaler technique been checked? If it was, and if it was poor, was a new inhaler issued? And next was advice provided on other risk factors like smoking cessation or avoidance of other trigger factors. And then make a decision on whether to refer the patient if severe asthma is suspected, because all patients with suspected severe asthma should be referred to a specialist so that a diagnosis can be confirmed, and if they do have severe asthma, so that one of the new biologic treatments could be offered. Now have a look at the template that I've provided on the website. You'll see that it summarizes the risk factors which I think should be considered when assessing these cases. And that'll help you in the practice to prevent asthma attacks by making sure that your patient's asthma is well controlled. And having gone through these cases, make sure that appropriate action is delegated to appropriately trained staff to implement. So if it's a case of checking inhaler technique or issuing a new type of device, if your practice pharmacist has had training in that area, then that would be the ideal person to do that. If the person needs quite substantial modification to treatment, then the care should be delegated to somebody with appropriate training, which might be a nurse with diploma level training in asthma or a general practitioner. And then refer all those patients who've had 2 or more attacks in the last year. And this goes back to the recommendation of the National Review of Asthma Deaths in 2014. More than 3 asthma treatment drugs which have been prescribed, that's in addition to rescue short-acting beta agonists, should also result in a referral to a specialist. And anybody on high-dose treatment for asthma who is still having attacks or poor symptom control should be referred to a specialist. Okay, so now comes the fun part where you assess progress of the work that you've been doing in your practice. Have you really achieved your aim of making your practice much more asthma aware, and are you on target to reducing or even eliminating asthma attacks in your practice by 2025? So have you met the standards that you set that you wanted to achieve, including coding, and that's coding of asthma attacks and coding of asthma? Have you done reviews, that's post-attack asthma reviews, and have you reviewed all asthma attacks that have occurred in patients in your practice? And then look at some numerical outcomes. How many of your asthma patients have had attacks, and what proportion of those were repeat attacks? In other words, was their asthma not well controlled even after they'd had an attack? Were there not modifications made to the patient's care after they had an attack? And repeat attacks could be within a year or within 3 months, or whatever time period you decide is acceptable. I think patients should not have repeat attacks within 3 months. If they're having them more frequently, it's a signal they may have severe asthma or that their asthma is not well controlled. And then number of referrals of your patients to specialists. And if you look at the results of those referrals, you'll be able to determine how accurate you were in making those referrals and whether your patients benefited or not. And finally, in summary, after 60 years of knowing about preventable factors in asthma deaths, particularly in the United Kingdom, it's really time to change. Healthcare professionals need to take control. I don't think we should be waiting for politicians to tell us what we should be doing or to set payment for asthma care in primary care. It's not happened yet, and I doubt it's going to happen, certainly not going to happen in my lifetime. So I think healthcare professionals need to take responsibility for asthma, just the same as they do for other chronic diseases. And that starts with the recognition that asthma is a chronic disease, and asthma attacks are signals that that chronic disease is not well controlled. Now see my website, bigcatdoc.com, for more materials related to these reviews, the 7-step plan that I've suggested, and imagine or dream or hope that your practice can actually reduce your workload and improve your patient care by abolishing asthma attacks in your practice. Thank you for your attention.